Okay, so welcome. And I'm glad you are spending your time with us. Today, as you can see, the topic is anorectal pain. So, MCCQE1 Objective 3.4. We did the last time, we did Objective 3.3. Now today we are doing Objective 3.4, anorectal pain. The reason I want us to look at this is because it's an objective a lot of candidates, they really struggle with it. A lot of candidates really struggle with this particular objective. And because of that, I was like, you know what? It's necessary that we take time to review this. A lot of candidates don't even know what the MCC objective is all about. And so a lot of them just come in, okay, what book am I supposed to study? Then they go and get a particular book, whether Toronto Notes, Master the Boards, whatever, and they are using to study. And that is why there's an abysmal performance among IMGs in the exam. About 56% pass consistently over the past, 2-3 years, which is not very good. And the average pass mark is around 227, 228. And we know that the pass mark itself is 226. So the point is, if about 46% are failing and those who are passing, the average mark is 227. That means we are going to get very little representation so far as the practice-ready assessment program and the residency program is concerned. And that is why at MedCognito, we do what we are doing. So today, I want us to really go into this. The rationale for this particular objective is that anorectal pain can be associated with potentially serious underlying pathology. So my first question for you is that if you are in an exam setting and you are presented with a patient with anorectal pain or anorectal discomfort, what are some serious, potentially life-threatening underlying pathologies that you want to know? I'll go with anal cancer. I'll go rectal cancer. I'll go with something like severe, even inflammatory bowel disease, if not picked up well. Because the rationale is that anorectal pain can be associated with potentially serious life-threatening pathology. Thank you. Somebody wrote inflammatory bowel disease. That's powerful. So anal cancer, rectal cancer, inflammatory bowel disease, because that can be very debilitating and that can be life-threatening if not managed well. However, most cases or causes of anorectal pain are treatable. So Dr. Aaron, you said I'm watching you from Facebook. You said diverticular disease and hemorrhoids. Diverticular disease, yes, can also be a life-threatening one. Usually hemorrhoids are not life-threatening because if you're able to manage the hemorrhoids are managed on a day-to-day basis. And I'll be coming to that as well, okay? But diverticulitis is serious because diverticulitis, they can get colonic abscesses, they can get perforation. So diverticulitis, anal cancer, rectal cancer, inflammatory bowel disease. These will be very powerful. So early identification and treatment are important to reduce morbidity. So in other words, when you are thinking through these various cases, and after that, I'm going to give you a list of cases I want you to master for this exam. You have to start thinking, what are the early things what are the early signs? What are the treatable symptoms? What are the things I'm going to do to be able to pick this up? The trick is that the rationale should guide you about how to list your differentials and areas you want to focus on when dealing with anorectal pain. Because as I said, the first rationale was talking about, the fact that there can be life-threatening conditions, and we've already looked at some of them. Inflammatory bowel disease, diverticulitis, if not managed properly, rectal cancer, anal cancers, right? So these ones, please, if I were you, because we are studying, I will list them quickly because the rationale talks about it. And if I go into the exam and, I'm asked about differentials for rectal concerns, some of my top differentials would be some of these things which can kill the patient. Because remember, in every MCCQE1 exam, you want to list those things which can kill the patient first before you go on to list the other things. But while we are learning this, I also want you to understand another thing and another reason why you should focus on specific things. Two conditions I want you to also master will be hemorrhoids and anal fissures. The reason is because I always say when I'm teaching that common things are common. Common things are common. If you're going into a board exam, you expect to meet things which are common. Why am I talking about hemorrhoids and anal fissures? There are more than 2 million outpatient evaluations of hemorrhoids in North America every year. Every year. So if you are preparing to go into residency, whether into family medicine, surgery, gastroenterology, whatever, at least you have to know that some of the common concerns you may be meeting in the clinic will be hemorrhoids. Number two, anal fissures, you get that about 1.1 cases per 1,000 person years. And so anal fissures are also very common. So if I were you, number one, what are the life-threatening things which can kill a patient with anorectal presentations? I'm going to learn my diverticulitis. I'm going to learn my anal cancers. I'm going to learn my rectal cancers. I'm going to learn my inflammatory bowel disease. Number two, I'm also going to learn the common things because hemorrhoids are common. Anal fissures are common. What am I going to learn about them? How will hemorrhoids present? Number two, how will anal fissures present? Then, how am I going to manage a patient with hemorrhoids? How am I going to manage a patient with anal fissures? If I'm able to master these, I'm good. Okay, so I want to continue. Please, are we all on the same page? If you're all on the same page, let me know. I don't want to rush anybody, you know?
Yes.
Family. We are family. We are family. So far, what have I said? So far, what have I said? Can somebody summarize everything I've said so far for me? What have I said so far? Tell me. Can somebody summarize? Because we have a lot of stuff to cover today.
Yeah. You said that causes of the anorectal pain, which can kill the patient. And the most important diagnosis, we will list it that whenever an exam question comes, first we have to list like inflammatory bowel disease, diverticulitis, and rectal cancer, anal cancer, but we should not forget hemorrhoids and anal fissure as they are very common in North America. So we will encounter a lot of patients in residencies. Yeah.
Beautiful. So you see, the whole essence of the exam is that any regular Canadian doctor should be able to deal with some of these things. We deal with hemorrhoids all the time. We deal with anal fissures all the time. So let's get going. Now, the key objective is that given a patient with anorectal pain, the candidate will complete a relevant history and physical exam and other pertinent investigations to determine the most likely diagnosis. Okay, the candidate will then initiate an appropriate management plan. In particular, the candidate should be cognizant of risk factors or symptoms which are suggestive of underlying disease. So if I pick this particular objective, let me go to my whiteboard and then let's look at something here. What am I supposed to know? Differentials. Number two, historical features. Number three, risk factors. And number four, management. Now I'm going to take you to the MCCQE1 website itself. And then we will look at the number of, like the way these cases are distributed so that we will know how we're going to deal with it. So let me go to the MCCQE1 website and then show you how they will distribute this for you. Let's go there. So you will understand and appreciate this. Yesterday, and I'm not going to mention anyone's name, but yesterday I got a message. Oh, Dr. Bruni, I want to enroll in your ethics course only. I was like, okay, sure, that's fine. But I don't think that's the thing which you should focus on mostly. So for example, can somebody use this as we go through the dimensions of care to help the whole class about what we're talking about? The question says we should learn about the history, the risk factors, the investigations and management. Now, so in anorectal cases, remember, you have to, it carries a lot of marks, how you're going to diagnose the patient based on history. That carries like that. If I'm supposed to be an examiner and if I'm supposed to drop, you know, questions for your QE1, according to the dimensions of care and the physician activity table, 45+5% of those cases should be about how you're going to make the diagnosis, how you're going to assess the patient. So you realize that today in the discussion, I'm going to drop a lot of issues on what are the pointers for you to know that this is the diagnosis, this is the diagnosis, this is the diagnosis. Number two, the next level of cases, which will carry a lot of points, should be how you're going to manage them. So every case, if you get this particular case, how are you going to manage it? If you get this particular case, how are you going to manage it? Then we'll also come to acute, because you realize that acute and chronic, what are the acute causes of anorectal pain and anorectal dysfunction? And then what are the chronic cases? If you're able to master assessment, diagnosis, management, and then acute presentations and chronic presentations, you're good. For example, chronic presentations, inflammatory bowel disease, somebody said it, diverticulitis. Diverticulitis may have its acute presentation and chronic presentation. And what are you going to do to prevent, flare-ups of underlying of a patient with diverticulosis, so that the patient does not get into diverticulitis? Number three, how do you assess a patient with anorectal cancer, fistula, fissure, anal fissure, fistula in ano, all the various differentials, and how are you going to manage all of them? So this is going to be our focus for today's discussion. So let me go back again. So you have to, now we've learned the objective. We're also learning the way we are going to be marked based on the objectives using the dimensions of care. So we've already seen that in the exam itself, they are saying that I must be able to complete a relevant history, a relevant physical exam, other pertinent investigations to determine the most likely diagnosis. And a candidate will initiate an appropriate management plan. In particular, the candidate should be cognizant of risk factors. So there are some specific conditions that you realize that I'll be quizzing you on risk factors as well. And after that, I'll be teaching as well. So don't worry about it. Okay. So, and then the enabling objectives are that given a patient with anorectal pain, the candidates will list and interpret critical clinical findings, including history of the rectal pain. That's number one. Number two, bleeding. Number three, disturbed bowel function. Number four, anal trauma. Results of an appropriate examination, including digital rectal exam. List and interpret investigations, including laboratory investigations, endoscopic examination, and construct an effective initial management plan, including determining whether the patient requires urgent surgical treatment. So all the cases we are going to learn, you have to find out which one am I going to refer urgently to a surgeon, okay? Counseling the patient about conservative treatment options in case of hemorrhoids and anal fissures. So you see, I told you that the statistics tells us that anal fissures and hemorrhoids are very common. Now in the objective itself, in the enabling objective itself, look, number two, counseling the patient about conservative treatment options in case of hemorrhoids and fissures. You see, that's why I always say that, why should you go into this exam saying that I don't know what to study for the exam? If you have the right mentality, if you have the right coach, like if you're going through this systematically, you realize that if your coach is that good, he'll be hitting on the necessary things because the objective talks about it. So you can't tell me you are prepared for the exam when you've not mastered anal fissure, presentation, how are you going to investigate it, management, and hemorrhoids. That is a no-no. All right. And then counseling the patient about future preventive measures like condom use for anal intercourse. Why? Because I'll be quizzing you on a particular question about a particular risk factor for a particular concern, and you will understand why this objective is there, and referring the patient for specialized care if necessary. Please, are we all on the same page? Because we are now about to fly. But I wanted us to see why I said certain things, and they are all in the objective. So can somebody tell me, if you pick a case of anorectal pain, what am I going to be looking out for? Let me know. Tell me. What am I going to be looking out for? What am I going to be looking out for?
Bleeding.
Hello?
Bleeding.
No, I'm not even talking about that. I'm just talking about before you even start learning. What are the things you want to know?
I will take, okay. I want to washroom.
Okay, you want to look at his lifestyle, his diet, his...
No, Dr. Mead, I'm even talking about what the examining body wants you to know.
Yeah, you want to know the differentials?
The differentials,
Yeah, the history and physical examination.
Physical exam,
The risk factors.
Risk factors, sure.
Yeah, the management.
And the management. Okay, sure. So now let's fly. So anorectal concerns can be confusing. And you realize that I'll be putting in some things which may confuse you, but in the long run, you'll appreciate because they share similar symptoms. Now, learn how to use historical features to differentiate them. So let's start with this case. I want somebody to read the case for me. Somebody to volunteer and read the case for me. I need a volunteer to read the case.
I can do it, Dr.
Please do that. Please do that. Please do it.
40-year-old male comes to the outpatient clinic with concerns of feeling uncomfortable in the anal region for the past 2 weeks. What 7 initial historical questions will you ask?
Beautiful. 7 initial historical questions you will ask in a patient who comes to the clinic or to the emergency room with anorectal concerns. What are your questions? What are the historical questions you want to ask? Because don't forget that the objective wants us to learn historical concepts, historical things you want to ask. So let me check it out. So I see questions. Bowel movement. Beautiful. Now, someone, even Dr. Rouge, the same Dr. Rouge clarified it. Bowel frequency. That is powerful. Dr. Eden was asking about bleeding. Beautiful. Dr. Fraser typed bleeding and pain. Dr. Fraser, please, in the exam, okay, don't write all of them on the same line. Write bleeding, and then after that, write pain on the next line. Then abdominal pain with bowel movement. Beautiful, beautiful. Dr. Mead went for pain. Dr. Mead, I want you to be specific. You know, you are my star candidate. Abdominal pain, bleeding. When you say lifestyle, what do you mean? I want you to go deep. The patient's diet. Beautiful, beautiful. Ask about urination history. Well, Dr. Fariba, that may be necessary, but not so. That's not first line historical features. So Dr. Fariba is asking about diet, bowel movement, pain. Beautiful, beautiful. Bowel movement, diet, constipation, according to Dr. Omed, and so many people. Sexual orientation. Oh my goodness. Dr. Mwembo, that is powerful. Powerful, powerful. Sexual orientation. Now, let's get into some of the answers. History of bleeding, anorectal bleeding is one of the things. Number 2, history of anorectal pain, because don't forget that the question stem said that the patient has discomfort, but does the patient have pain? Number 3, is there any perineal drainage? Is there any drainage as well? Number 4, is there any pruritus? Is there any pruritus? That's also another important question to ask. Number 5, is there a history of prolapse of tissue? Now, assuming the patient tells you that there's prolapse of tissue, what 2 differentials are you going to think about? What 2 differentials will you think about? If the patient says, doctor, it feels like something is protruding out of my rectal region, what 2 differentials will you think about? Can somebody help me? Can somebody help me? If the patient says, doctor, I feel that something is protruding through my anus, what will you say?
Hemorrhoids and rectal prolapse.
Beautiful. And that would be hemorrhoids and rectal prolapse. So you see, these are the historical features you want to find out from the patient. Bleeding, perianal pain, perianal drainage, pruritus, history of prolapse, number of bowel movements per day. Number of bowel movements per day. And then, does the patient strain during defecation? Because if you strain during defecation, and after that you have something popping out of your
Doctor, I can't hear you.
Sorry, can you hear me now? Can you hear me now?
Yes, yes.
Yes, now yes.
So if the patient strains, and because of that, it brings out something from the anal region, trouble, okay? Then you know that maybe there's a form of prolapse. Now, time spent during defecation. And what is the patient's cleaning routine? Is the patient using any bowel regimen What about unintentional weight loss? I didn't see anyone saying that. Because remember that one of the key things we're talking about are the life-threatening causes of anorectal pain. Life-threatening cause of anorectal pain. So weight loss is also part. Change in bowel habits. Change in bowel habits. And is there a history of recurring abdominal distension or abdominal pain? Because inflammatory bowel disease can do that. And we said that inflammatory bowel disease was one of the things we're going to inquire about so far as life-threatening causes of abdominal pain or perineal disease were concerned. Then, is there a family history of inflammatory bowel disease? And then, is there a prior endoscopy? Has a patient done any prior endoscopy? And has there been any recent endoscopy? And if yes, what was the result? So please, before I move on, please make sure you write this. Don't forget that we'll send you this video again, and it will also be in the Facebook group anyway. But I want you to know, if you go into your board exam and you are asked, what are the initial things you want to know? These are some of the things you want to hit on. If you're able to memorize about 5 or 6 of them, we're good. Is that okay? Please, can I move on? I don't want to move on if you don't want me to move. Can I move on now? Hello, doctors, please, can I move on? Yes, okay.
Yes.
So we've learned about the historical features, which deals with one of the main objectives. Now, you remember that the question was that the patient feels discomfort in the perineal region. Assuming the question throws in the issue of pain, you have to, when there's an issue of pain, a little anatomy has to come in. And this is nothing wild. I'm just going to show you something. The reason is because you have to remember what we call a dentate line. This one, the dentate line, the dentate line, the dentate line, the dentate line. The reason is because as different way the anal region is innervated below the dentate line, and there's a different way the anal region is innervated above the dentate line. Most of the time, I'm just saying something, most of the time, lesions above the dentate line are not painful. So if you learn your differentials, number 1, and the patient presents with anorectal discomfort, but then the question says there is pain, then start thinking about differentials of conditions which fall below the dentate line. Please, are you following me? I want to make sure this is clear because we are throwing in a different concept. After we've gone through the historical features, we are throwing in another concept of perianal pain. I said that the dentate line, the area above the dentate line is innervated differently than the area below the dentate line. In fact, the mucosal lining and the epithelial lining of the area above the dentate line is different from the area below the dentate line. Most of the time, I'm not saying all the time, but one exam trick, most of the time, if a patient presents with anorectal pain, then it is likely that the issue is below the dentate line. What do I mean by that? When I talked about the dentate line, the anal canal, you have to understand this part, this thing, the anal canal, this one, the anal canal. It is divided into 2 halves, which I've said already. And it is separated by the dentate line. Now, the distal half is lined with anodem, and it receives somatic innervation. Somatic innervation. And because of that, they are sensitive to painful stimuli. So this part, again, the distal part, this part, please, can you see it? Please, I want you to really see it. Can you see it? This part.
Yes, doctor.
Beautiful. This part is supplied by, somatic nerves. And because of that, they can pick up pain a lot. The proximal part, that is the upper part, they are lined by different types of epithelium. You don't need to worry your head about this. But I'm just saying that always keep this in mind. So if you get an anorectal issue and there is the issue of pain, it helps you. That one has autonomic innervation. And because of that, the patient usually does not feel pain. So let's go back again. Dentate line, area below anodem, area above columnar epithelium, area above, not very likely to pick up the issue of pain. Area below, very likely to pick up the issue of pain. So now let's move on. Now, because of that information I've given you, dentate line, above, no pain, below, pain. Let's break down the differentials. So can somebody read this question for us then? Let's use that, because in MedCognito, we use questions to, we would twist it around and just so that you're able to pick it up well. Somebody should volunteer.
A 43-year-old male comes to the outpatient clinic with concerns of feeling uncomfortable in the anal region for the past 2 weeks. On further questioning, there is generalized perianal pain, but the skin in the peripheral skin, perianal skin, appears grossly normal with no changes. What is the likely diagnosis? Anal fissure, anal fistula, hemorrhoids, pleuritis, ani, or rectal cancer?
Beautiful. 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 Dr. Omar, thank you. Dr. Omar, what's your answer? 43-year-old male comes to the outpatient clinic with concerns of feeling uncomfortable in anal region for the past 2 weeks. On further questioning, there's generalized perianal pain. So, Dr. Omar, even before you move on, where do you think the lesion will be? Above the dentate line or below the dentate line?
This is painful?
Yes.
There you go. So it's below the dentate line.
Below, okay. And the skin in the perianal region, skin up grossly normal with no changes.
Right.
So what is the likely diagnosis?
Maybe anal fissure?
No. Take your time. Why anal fissure? Why anal fistula? Why hemorrhoids? Why pleuritis anal? Why rectal cancer? And you are going for anal fissure. Does somebody have a different answer?
Isn't anal fissure painful, doctor?
Anal fissure is painful. I'm not doubting that. Anal fissure is painful. Yeah.
It could be a hemorrhoid. Could be hemorrhoid.
It could be a hemorrhoid. It could be an anal fissure. But the question is that will the skin? Okay, so now you are telling. Let's go through this. You are saying that it could be anal fissure. It could be a hemorrhoid. I have a question for you.
Yeah.
In hemorrhoids, does the skin look normal?
It doesn't look normal.
Doesn't look normal. Okay. In anal fistula, does the skin look normal? No.
It doesn't look normal.
In anal fissure, does the skin look normal?
It doesn't look normal.
Beautiful, because at times you may see the crack, right?
That's right.
In rectal cancer, will the skin look normal? No. So what among these differentials will the skin look normal?
Peritis, maybe ani?
Or yes,
Go ahead.
and I'm going to explain why.
Thank you.
I'm going to explain why. Pleuritis ani can cause perianal pain. I think maybe you confused it. You are thinking that, pleuritis ani will only be itchy. No, it's not only itchy. It will present with itchiness and at times perianal pain, especially when the perianal skin appears grossly normal or with minimal changes. Since pleuritis ani relates to hypersensitivity of the cutaneous nociceptive nerves, that is why there's pain, as opposed to skin changes. So please take it again. Number one, pleuritis ani, it will present with itching in the perianal region and pain. The clue about pleuritis ani is that the skin around the perianal region looks normal. We've learned that anal fistula will not be normal. Right. Anal fissure, at times you see the fissure. Anal cancer, no, you will see something. Hemorrhoids, you'll also see something. So the only concern which will present with pain, discomfort in the perianal region, but the skin will look normal, is pleuritis ani. Doctors, please, can I move to the next stage?
Yes. Thank you, doctor.
Beautiful.
Very good.
Please, can I move to the next stage? I really want to make sure that you are comfortable before we move. Can I move to the next stage? Beautiful. Now, will Dr. Omar want to take it again, or someone else who want to try? Will somebody want to try, or Dr. Omar will take this case for us? Dr. Omar, since everyone is quiet, will you want to take it for us, please?
Yeah. So we have a 43-year-old male comes to the patient clinic with concerns of feeling uncomfortable in the anal region for the past weeks. Discomfort has become extremely painful in the last.
Please, it's the last 2 days. It's the last 2 days, not 3 days, not 32 days. Let me correct it right away. In the last 2 days, sorry, that was a mistake. Dr. Ma, let me correct it before we move on, okay? Beautiful, beautiful. Please, Dr. Ma, let's go.
Okay, so painful in the last 2 days on physical exam. You see this lesion below. What is your diagnosis? List 1.
Beautiful. Dr. Ma, this time it is not an MCQ. This time it's a CDM.
Yes, yes. So this is completely blocked. This is
okay.
There's no canal. Is this? I don't know.
No. You know it.
Okay.
You know it. You know it.
Now, this could be, yes, a thrombosed hemorrhoid. Yes, hemorrhoid.
Beautiful. This is it.
Yes.
It's a thrombosed hemorrhoid. I think you got confused because it is, but it is because it's thrombosed, so it's become so big. And look at the way the question presented it. So it looks like maybe the patient may have the discomfort, but in the last 2 days, that hemorrhoid has become engorged with blood. And because of that, it is so big that it is covering the area. So that's your diagnosis. Thrombosed external hemorrhoid.
Thank you, doctor. Thank you.
Beautiful. So thrombosed external hemorrhoid, the teaching point is that they cause localized perianal pain. Localized. Number 2, it's a spot diagnosis. When you see it, you must be able to see that, no, this is a thrombosed external hemorrhoid. It can cause ulceration of the overlying skin. And this is a trick. If the patient is evaluated within 72 hours of the thrombosis, a bedside incision and thrombectomy can be performed. So, for example, I said that the patient's thing got worse in the last 2 days, right? That's 48 hours. So in the clinic, you can even give some local anesthesia and you can do an incision so that the thrombosis can be extruded. The interesting thing about that is that most of the time it can reform quickly, okay? But if I had told you in the question stem that you saw that there was non-viable skin over the thrombosed area, the best thing for you to do is to refer the patient to a surgeon right away. So please, the teaching point is this: know how to see and identify a thrombosed hemorrhoid. Doctors, we've talked about pruritus any. We've talked about thrombosed hemorrhoids. Preparing for the Q1 is fun and it's very simple. Please, can I move on?
Yes.
Pruritus any and thrombosed hemorrhoid. Please, doctors, can I move on? Everyone, can I move on? Facebook guys and those on Zoom.
Hey, Dr. Brown,
yes,
just to reiterate, so if it's past 2 days, then we refer. Is that what you said?
No. So what I'm saying is that if it is within 3 days of thrombosis, you can easily make an incision and drain the thing.
I agree.
The literature says that if it is above 3 days, you just want to leave it, let them do sit baths, and then send a referral to the surgeon.
Thank you.
Yeah.
Thank you.
But one of the indications for referral of a thrombosed hemorrhoid is if there is excoriated skin over the area of the thrombosis, then that's once you want to get a surgeon involved. All right?
Very good.
So, yeah. I think some people.
Hello, Chief.
Hello,
so,
sir.
Sorry.
Please join. Yeah, please speak.
Yeah, the other question that was, sorry, I came late. I wanted to know what.
Which other question?
Yes, yes, this one for this. What makes this? Because now they said feeling uncomfortable in the perianal region for the past 2 weeks.
Yeah.
What differentiates this from having an anorectal abscess?
Oh, we will come there. Don't worry. We'll come there. We'll come there. Don't worry. I've gotten you. We'll come there. I knew what you were going to ask. That's why we have a special. So please hold on. In fact, don't go away. This is another thrombosed hemorrhoid. And this one, Dr. Umar, realized that the skin over it is excoriated. If I should show you this in class and I ask you what's your next best step, your next best step is I'm not going to incise this. I'm going to refer to a surgeon. So this is one of the things you're going to refer to a surgeon right away. Okay, good. Someone asked a very important question. Beautiful. So please, I've forgotten who was it Dr. Eugene? Who was asking the question right now?
Dr. Emmanuel.
Dr. Emmanuel, now take this question for me. Can you read the question, Dr. Emmanuel?
Okay, it said a 43-year-old male comes to the outpatient clinic with concerns of feeling uncomfortable in the perianal region for the past 2 weeks. His comfort has become extremely painful and perianal drainage. Okay, then the vital signs was the blood pressure 120/80 normal, pulse 87, respiratory rate 16, temperature 38.2. What is your likely diagnosis?
And what is the next best step?
Okay, what is the likely diagnosis? Chief, I could have gone for an abscess.
Oh, so you realize that, and unfortunately, Dr. Fariba and Dr. Frost, I've seen your answers. No, it is not anal fistula. We will come there. This is not anal fistula at all. I've seen multiple patients with anal fistula. They don't present with fever. In other words, if I should break down this question, it's a 43-year-old male who has had perianal discomfort for some time. Recently, it's become very painful, plus fever. That's all. That's all that this question is asking about. Perianal discomfort, extremely painful, plus fever and discharge. Fistula will have discharge, but fistula will not have fever. Before, if the patient because as soon as it becomes a fistula, the thing is constantly draining, and because of that, the patient is not going to mount that immune response and develop a fever. But if it is enclosed, then an abscess will form, and if an abscess is forming, then that is when the patient will have the fever. So, Dr. Emmanuel, now that you've identified that this is perianal abscess, what's your next best step?
My next best step is to do. I'll do an incision and I'll do incision and drainage.
Exactly.
Yes.
Why are you waiting? But most of the time with perianal abscess, you don't want to do it on your own. So the answer is a perianal abscess. Why? Because of the fever. And I'm going to give you other features. And then how am I going to manage it? I'm going to refer to a surgeon for drainage of the abscess. That's all. That's all.
Yes.
So now are you seeing? So when we throw in the issue of fever, when we throw in the issue of discharge, then you know that these guys are talking about perianal abscess and not anal fissure and not fistula. Now, let's talk about perianal abscess then, because you asked the question. Most of the time, the patient will present with severe perianal discomfort. There will be fever. There may be perianal drainage. There may be erythema. The way when somebody has an abscess, the area of the abscess becomes red. There may be induration. It may be fluctuant. So if I wanted to, confuse, I could have also put in that when I did a physical exam, the place was very, very fluctuant. How am I going to manage a patient with perianal abscess? Incision and drainage procedure is required urgently, but most of the time it should be done by a surgeon. Remember, in the exam, when we looked at the dimensions of care, how to make the diagnosis, how you're going to manage. How to make the diagnosis, how you're going to manage. How you're going to make the diagnosis, how you're going to manage. Two things. This is not a time for you to go and read extensive literature. QE1 preparation is targeted. It is not the one who has read broadly. No. You can have somebody who has read Toronto Notes back to back. And you can have somebody who has also focused on what the dimensions of care is saying. Every condition, risk factors, differentials, How am I going to make a definitive diagnosis? How am I going to manage complications? The person moves on. Pa, 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 move on. Pa, pa. That's how you do it. That's how you have to prepare for QE1. I don't know. Let me check whether somebody has. Is there access? If there is access, no, there is no access if there is access. However, at times the abscess may drain. The fact that an abscess is draining does not mean the patient has developed a fistula, because we'll be coming to the fistula as well. So I want somebody else to read this case for us. Somebody to read this case. We are looking at, you see, we are using the cases to look at the various presentations. So we are now looking at perianal abscess. We finished that. Perianal abscess. Who wants to volunteer? Please, I need a volunteer.
43-year-old male comes to the outpatient clinic with concerns of feeling uncomfortable in the anal region for the past 2 weeks. He feels pain in the anal canal. Which of the following is not likely?
Beautiful.
A.
Okay. No, please read. Please.
A, anal fissure. B, anal cancer. C, anal ulceration caused by sexually transmitted infections. And D, internal hemorrhoids generally do not cause anal pain.
I gave myself away, but what was the answer? 43-year-old man comes to the outpatient clinic with concerns of feeling uncomfortable in the anal region for the past 2 weeks. He feels pain in the anal region. Which of the following is not likely? I gave myself away.
Yeah, D, of course. D.
The answer is D. And the teaching point is very simple. When a patient has discomfort, which is arising within the anal canal, that is the lesson. Within the anal canal, the differentials you should think about can be anal fissure, anal cancer, anal ulceration caused by sexually transmitted infection. Now, internal hemorrhoids generally do not cause anal pain. Do you know why? Because internal hemorrhoids occur most of the time above the dentate line. You remember we talked about the dentate line? Doctors, please, do you remember that? Do you remember that? We talked about the dentate line. Internal hemorrhoids usually do not occur about the dentate line. Maybe let me look for an image and then show you. Let me look for an image, internal hemorrhoids. Let me look for an image so that it will help you to stick. You realize that internal hemorrhoids usually do not occur above the dentate. They usually occur above the dentate line, sorry. Beautiful. I got a wonderful picture from the Mayo Clinic. I'm going to put it on the slide so that you can see it. So let's look at it again. Look at the way the question was asked. The patient is uncomfortable in the anal region and feels pain in the anal canal. Which of the following is not likely? Anal fissure will cause pain. Anal cancer will cause pain. Anal ulceration, because we've already learned that. But then look at where most internal hemorrhoids are. This is the dentate line. This one, this place. Internal hemorrhoids are forming here. And we said that the internal hemorrhoid, the innervation of the place does not allow them for you to pick up pain. So most of the time, the way we pick up internal hemorrhoids is when this thing breaks and then it starts bleeding. Then the patient will come, doctor, I have some blood when I poop. And then the doctor will refer the patient for proctoscopy or anoscopy. And then when they do the anoscopy, they say, oh, there's an internal hemorrhoid. And that is why you can also do band ligation of the internal hemorrhoid in the clinic without giving the patient any anesthesia. Do you know why? Because the patient is not feeling any pain there. Doctors, please, is it clear? I want to make sure that this is clear before I move on. Internal hemorrhoids, most of the time. So as compared to the external hemorrhoid is below the dentate line. And that is why external hemorrhoids can be painful. But internal hemorrhoids are above the dentate line. And most of the time, the only way you can pick it up, most of the time on history, is the patient will say that I've started seeing blood when I poop. Then Dr. Emmanuel said, okay, I need to refer you to a surgeon. then the surgeon will stick in a proctoscopy or anoscopy, and then the surgeon will see this. Most of the time, when the surgeon sees this, why is it that they're able to put a rubber band on it in the clinic? Do you know why? Because most of the time, lesions above the dentate line, as we've learned, do not present with pain most of the time. And that is why they can do the band ligation without anesthesia. So that's why they can do rubber band ligation in the clinic without anesthesia. So the surgeon will just put the thing there. Oh, okay, there's something there. Then they'll just put a rubber band on it. And then you realize that it will cut off the blood supply. And after a few days, the hemorrhoid will fall off and it is done. Why? Because about the dentate line. So this is a combination of some little anatomy and an appreciation of, you know, how various anorectal malformations will present on history and exam. Okay, good. I want another volunteer. Another volunteer. Or if someone wants to take it, that's fine.
I can take. 43-year-old male comes to the outpatient clinic with concerns of feeling uncomfortable in the anal region for the past 2 weeks. He feels pain in the anal canal, and the pain is present both when he is defecating and when he is not. On digital exam, the patient was in severe pain. What is your most likely diagnosis?
Beautiful. What's your answer? Is it anal fissure? Is it anal cancer? Is it an anal ulceration caused by sexually transmitted infections, or is it internal hemorrhoids? I should correct that.
It's anal anal fissure.
Beautiful. Why? So now we've learned how pruritus any presents. We've learned thrombosed hemorrhoid. We've learned anal perianal abscess. We just what did we just learn? We just learned something. We learned internal hemorrhoids.
Internal hemorrhoids.
And then now we are learning anal fissure. And the answer is yes, anal fissure. Why? The question says that he feels pain in the anal canal, and the pain is present both when he's defecating and when he's not. On digital, the patient was in severe pain. That's anal fissure. So in anal fissure, they will not even allow you to do a digital rectal exam. As long as you try to do it, they'll say, ow, ow, ouch, ouch. Like they'll be in a lot of pain. Okay. Now, the same question, please. The same person who read it, I like the way you read it. Please, can you take this other part for us?
Should I go with the whole history again? Or?
Yes, go to the full history again.
Okay. A 43-year-old male comes to the outpatient clinic with concerns of feeling uncomfortable in the anal region for the past 2 weeks. He feels pain in the anal canal, and the pain is present both when he is defecating and when he is not. On digital exam, the patient was in severe pain. Which intervention will you likely avoid? Choose 3.
Beautiful. What are your answers? This is a CDM.
Should I just go through the options first, doctor?
Yeah, go through it. Yeah, go through it.
So A, stool softener. B, urgent anoscopy. C, increased fiber intake. D, siege birth. E, topical nitroglycerin. F, topical nifedipine. G, urgent sigmoidoscopy. H, referral to the lateral internal anal sphincterectomy. And I, botulinum toxin A. I will go with B, urgent anoscopy. Another one, urgent sigmoidoscopy.
Beautiful. Beautiful. And I like that. Oh, you wanted to say something else?
I'm not sure about H, but I would definitely go for urgent sigmoidoscopy and urgent anoscopy, because those 2 will be painful.
That is a powerful thing you just did. In the CDM, this is the approach you take. If you are sure about something, you choose that. Even though the question says to choose 3, in reality, there are only 2 correct answers, and those are the ones you choose. Urgent anoscopy, urgent sigmoidoscopy. The reason is because the fact that we've written choose 3 does not mean that you definitely have to get 3 answers. No. So this is also teaching me, I can even just use this question alone because of her answers, that if a patient has anal fissure and the patient is experiencing a lot of pain, I should not force a digital rectal exam, number one. Number two, that is not a time to refer the patient for urgent anoscopy. The patient will not be able to tolerate it. Number three, that is not a time to refer.
Now, so this is also
that's not a time to refer the patient for urgent sigmoidoscopy as well. Okay, so if you're able to refer the patient, or if you're able to give some stool softness, encourage that the patient takes fiber diet, sits bath, you can give topical nitroglycerin, you can give topical nifedipine, you can even refer them for lateral internal anal sphincterectomy. And part of the management of anal fissure is botulinum toxin. All of them are treatment options. But when the patient is in pain, you don't refer for urgent anoscopy, you don't refer for urgent sigmoidoscopy. So what the doctor said was right. Those are the two answers which are correct. Because you see, in the exam, you have to be able to avoid dangerous things. If you go on to choose dangerous things or life-threatening things or limb-threatening things, things which can cause the patient to lose their limb, that can be very, very dangerous. So let's use this.
I have a question, please.
Please ask the question.
Yeah, sorry, please. For instance, if one chooses one other answer here, which is definitely going to be wrong, and then you have three, does it nullify the answers? Does it make your answer 0, or you get partial answer?
No, you will get 2 over 3. You'll get 2 over 3. But if I should have turned the question around, listen, if I should have turned the question around and I've said, on digital exam, the patient was in severe pain, which intervention will you like to do? Please look at this. And the person had gone on to choose urgent anoscopy or urgent sigmoidoscopy because that will cause severe pain to the patient. That is a dangerous answer, and that person would have been nullified. But this one, the question was saying, what would you like to avoid? And you choose urgent anoscopy, urgent sigmoidoscopy, and then, for example, you add sit baths. Even though sit baths is wrong, you will still get B and G correct. But if the question was the other way around, and you got 2 correct, and you added urgent anoscopy or urgent sigmoidoscopy, then you would have gotten 0. Please, are you getting the whole point? So you get 0 for everything when some of your answers are right, but you choose a dangerous intervention or a dangerous investigation. But in this one, it is not a dangerous investigation you choose, like sit baths and the rest. No. It is wrong because the question was, what are you likely to avoid? But then it is not dangerous. So you still get your 2 marks and you go your way. And I'm very happy about the way she chose her answers, because even though the question said 3 answers, she knew 2 of them and she chose those 2. And that's also acceptable. Please, can we move on now? I'm happy we are using this. I thought this was going to be a straightforward class, but I'm very happy that we are using this to learn a lot. Okay. So the teaching point is this: anal fissure will cause severe anal pain. There's constant pain, but further exacerbated by defecation. So that's why the question said that it is worse when the patient defecates. The diagnosis is that there's point tenderness on palpation of the anal verge. Okay. Now, you have to note something. A complete insertion of an examining finger or anoscopy should be avoided under these circumstances. So what should you know about anal fissure? This is all you need to know, plus management, stool softness, increased fiber intake, sit bath, topical nitroglycerin, topical nifedipine, referral for lateral internal anal sphincterectomy, and botulinum toxin. If you're able to learn these 2 slides, done. Anal fissure, you're done. That's all you need to know for the QE1 exam for anal fissure. Please, is the teaching point okay? Can I move on to the next one? Because we are using, so now we've done anal fissure as well.
I have a question.
Please ask the question.
Yeah, you said note a complete insertion of examining digit or endoscopy should be avoided. Can you do a partial insertion?
No, the issue is that, so the issue is that, so that's why the diagnosis points tenderness on palpation of the anal verge. So most of the time, what will tell you this anal fissure is that you pat the buttocks, as soon as you try to do a digital rectal exam, the patient shouts, and the patient does not have a fever, then that tells you, so that is like an attempted digital rectal exam. So when the patient shouts and the patient does not want you to continue, a complete insertion of the examining ligates should then be avoided. Are we okay with that?
So a partial one can be done initially.
Yes, because that is what even helps you to make the diagnosis anyway. Because at times that fissure will not be external. It may just be on the verge. So at times you are just trying to do your digital rectal exam and the patient will be in so much pain and there'll be the inner sphincter will just close. And then you realize that you can't continue. So as soon as you see that, it should tell you that no, this is most likely an inner fissure.
Can I ask another question? Sorry.
Please, no, don't worry.
Okay. So if a question says the following is contraindicated for digital rectal examination, inner fissure, true or false?
True.
So digital rectal examination is contraindicated.
It is not encouraged, no.
Okay.
The reason why it's like, is it ash, is it black or white? The reason, because most of the time, if anyone presents to you and the patient has any anorectal concern, one of the key things you want to do in the clinic is a digital rectal exam, right? Anytime, bleeding, whatever. So as soon as you attempt it, and then the patient, like, with anal fissure, as soon as you touch the anal verge, the patient will shout. The patient will be in a lot of pain. So you can't even complete the digital rectal exam. Yeah. Okay. Can somebody take this question for us? I want a volunteer. Dr. Betty.
Okay, can I read?
Okay, so
can I read?
Okay, yeah. Please read.
A 43-year-old gay man comes to the outpatient clinic with concerns of feeling uncomfortable in the anal region for the past 2 weeks. Feels pain in the anal canal, with associated rectal bleeding and a mass. What's the most likely diagnosis? A, anal fissure. B, anal cancer. C, anal ulceration caused by sexually transmitted infections. Then D, internal hemorrhoids generally do not cause anal pain.
So, sorry, as I said, I should have corrected this. This is just internal hemorrhoid. So what's your answer?
My answer is C.
So you're going for anal ulceration caused by sexually transmitted infection. Does somebody have a different answer? Dr.
It could be an anal cancer too.
Yes.
Anal cancer.
Or the mass.
Yes, it could be anal cancer or C, but the one thing we picks it up is
a mass. Mass. Is a mass. Yeah, that's a cancer, anal cancer.
And what else? A 43-year-old gay man. Why do I say that? The answer is anal cancer. Why do I say that? How will anal cancer present? So that's also another thing. If you're able to use this to review your anal cancers, you're good. Rectal bleeding is the most common initial symptom of anal cancer. Number 2, anorectal pain. Number 3, sensation of a mass. Number 4, anal squamous cell cancer has a history of, like, about 50% of them have a history of anorectal condylomata, which is present in 50% of gay men. Number 5, tumors of the perianal skin may be present. And at times they may even present with pruritus ani. So we learned pruritus ani initially. But what is unique about pruritus ani? Pruritus ani, usually we learned that there is no change in the overlying skin. But this guy has a mass. He has a risk factor. He engages in anal intercourse. And because of that, he has the likelihood of anal squamous cancer. And there's also a mass there. So he can have pruritus, he can have bleeding and mass. That differentiates it from pruritus ani. That even differentiates it from anal ulceration. Because anal ulceration is anal ulceration, but anal ulceration will never present with a mass. But as soon as you see a person is gay, there is a mass, boom, think about anal cancer. Please, is that clear now? Is it clear? Is it clear?
Dr. Bruni, can you tell again about anal cancer? For the diagnosed anal cancer, yeah.
Yeah, so the features of anal cancer that you should be looking out for as you study and as you prepare for your exam. They may present rectal bleeding, anorectal pain. They may have a sensation of a rectal mass. Now, one thing you have to understand is that anal squamous cell cancers, there's usually a history of anorectal condylomata, and it is present in approximately 50% of gay men. So so it's like warts, anal warts, okay? And then they may have a tumor, and they may also have pruritus. So anal bleeding plus anorectal pain plus a mass in a person who is gay, a gay man, and there's the feeling of a mass, think about anal cancer, right? Is that
Dr.
okay?
Boni, in the condyloma accuminata, it also comes in other conditions like anal genital warts. With the, that's the same one, condyloma.
No, because don't forget that the causes of warts, there are various strains of the organism, right? So it could be that it is the cancer forming type which formed that kind of warty lesion at the anal region of this particular gentleman, right?
Okay, thank you so much. Yeah, thank you.
You're welcome. Okay, so further teaching points. Anal concerns, if the patient has anal concerns plus bleeding. So if you see any case, anal discomfort, not anal pain per se, but anal discomfort plus bleeding, one of the differentials which should come into your mind should be three things. Number one, anal fissures. Number two, internal hemorrhoids. Number three, anal neoplasm. Now, how will I differentiate anal fissure from internal hemorrhoid? Internal hemorrhoid most of the time will not present with pain, but they will present with bleeding. Anal fissure can present with bleeding and pain. And how will I differentiate anal neoplasm from these two? Most of the time, this will present with a mass. And I have to look for a risk factor, like if the patient is a gay male, then that is easy for me. So anal concerns, anal discomfort plus bleeding, three differentials I should never miss: anal fissures, internal hemorrhoids, anal neoplasm. The anal fissure, the patient will not allow digital rectal exam. Internal hemorrhoids, most of the time there is no pain, you just see bleeding. Anal neoplasm, there may be pain plus pruritus. Maybe the person is a gay, then there may also be bleeding, and then you may also see a mass. Now, external hemorrhoids are generally not a source of bleeding except when they are thrombosed. Okay, so you see, we are using this whole anorectal pain thing to really learn a lot. So I want you to also note this particular equation. If there's rectal bleeding plus severe anal pain, which is provoked by defecation, think about anal fissure as well. I think we've already dealt with this, but the reason why I keep going back to anal fissure and hemorrhoids is because the objective says that you have to master those two as well. So you should be able to pick up anal fissure, hemorrhoids in any way, shape, or form that it is presented. So a critical point I also want you to notice that all patients who present with anorectal bleeding should undergo a diagnostic colonoscopy unless there's a compelling reason not to. And that is, for an example, a patient with anal fissure. Because we learned that anal fissure presents with extreme pain and at times bleeding per rectum. But that is not a time for you to send a patient for colonoscopy. But aside, if you rule out anal fissure, if you try to do your digital rectal exam and the patient does not present with any pain, then refer for colonoscopy. The other thing you shouldn't also lose sight of is don't go saying, oh, this patient is just 25 years. This patient is just 35 years and he has bleeding per rectum. Therefore, I'm not going to send for colonoscopy. No. Young adult age is not a reliable reason for omitting a colonoscopy in a patient with rectal bleeding. Young adult age is not a reliable reason for omitting a colonoscopy in a patient with rectal bleeding. So let's talk about anal discomfort and prolapse. If you see a patient with anal discomfort and prolapse, what differentials will come into your mind? Can somebody help me? Anal discomfort and prolapse, what differentials will come into your mind?
Rectal prolapse.
Rectal prolapse and what else?
Hemorrhoid.
Right.
Beautiful. Prolapsed internal hemorrhoids and rectal prolapse. Two differentials which should come in. You see, I'm very happy about the way people are now catching on with the various, things. Is there prolapse? Is there discharge? Is there pain? Is there bleeding? I'm very happy about the way. So if you see something which has prolapsed through the inner region, think about two things: rectal prolapse, think about prolapse internal hemorrhoid. So what's your diagnosis here? And this image is from up to date. What's your diagnosis?
Rectal prolapse.
Rectal prolapse, because of, these circular things you see there. It's straight up rectal prolapse. This picture shows full thickness, complete rectal prolapse. All right, can I move on? Can I move on, please? Can I? Okay, good. The guy say I should move on. Okay. Now, another case. 43-year-old gay man comes to the outpatient clinic, concerns of feeling uncomfortable in the inner region for 4 days. There's drainage from the inner region. List 3 differentials. Drainage from the inner region. List 3 differentials.
Abscess.
What abscess? Is it abscess from the
Perianal abscess?
Okay, then what else? Beautiful. What else?
Anal
Cancer?
fistula.
Anal cancer?
I know why you're
Fistula.
saying that. And then someone is also saying fistula. So now we're also learning. So we've learned perianal region with itching. Then we learned perianal region, perianal discomfort with pain. And then we've learned perianal discomfort with prolapse. And now we are learning perianal discomfort with discharge. So anal fistula, fecal incontinence itself, hyalonidal cyst as well, perianal hidradenitis, and then perianal skin cyst. These are some of the differentials. And of course, because I said that the patient is a gay as well, then all the other differentials we're also thinking about. But remember that anal cancer, the predominant symptom can be bleeding. So anal fistula, fecal incontinence, pilonidal cyst. Now, 43-year-old gay man comes to the outpatient clinic with concerns of feeling uncomfortable in the anal region for the past 4 days. You see the following on physical exam. You see this on physical exam. What's your diagnosis?
Fistula.
Anal fistula. Why? This is the anal canal.
There is a fistula. Yeah.
And this is
There's opening of the fistula.
this is another fistula which has opened. So you see, we have used a step-by-step approach to go through all these critical things. So another question. 43-year-old gay man comes to the outpatient clinic with concerns of feeling uncomfortable in the anal region. Careful examination did not reveal any area of discharge apart from the anal passage. Patient, however, has decreased anal sphincter tone. What is your most likely diagnosis?
Fecal incontinence.
Oh my goodness. Now I can sleep today. Now I can sleep today. Do you know why? Because people are able to pick things up. So fecal incontinence, it is similar to those fitting for an anal fistula. However, examination for fecal incontinence would reveal no evidence of an anal fistula. Remember that the anal fistula, there was another passage apart from the anal canal itself. But when it comes to the anal incontinence, it is just the anal region, and there is diminished resting sphincter tone. So with anal fissure, when you attempt to do a digital rectal exam, the sphincter tone increases. But with fecal incontinence, the fecal tone is diminished. Hello, doctors.
Dr. Bruni, I have a question.
How is your Sunday going? Is it making some sense?
It's going good. Credit goes to you.
Oh, no. Credit goes to you for listening quietly and, following the step-by-step approach. Okay. So somebody had a question. Please ask the question.
Yeah. It's just something about semantics. Anal fistula, is it the same as the fistula in anal?
Yes, sir.
Okay. Thank you.
Yeah. Okay, so 43-year-old gay man comes to the outpatient clinic with concerns of feeling uncomfortable in the anal region for the past 4 days. There is pain and drainage from the perianal region, and notes the following below. What's the diagnosis? What's the diagnosis?
Pilonidal cyst.
Because it's even in the reference. Pilonidal disease. So you see the way each of these has presented. Pilonidal disease, abscess, fecal incontinence, rectal prolapse. We've used questions to learn all of these. And for me, I'm very happy about it. So pilonidal disease, there may be pain and or drainage. And what I want you to do is, when we are done, go to Google and Google a lot of, images of pilonidal disease, so that you can make a spot diagnosis. If you see it in real life, or if you see it on your board exams or something, you should be able to identify. So pilonidal disease. So today we've
Please,
learned...
can I see the picture again?
Sure.
Okay.
Yeah.
Okay. Thank you.
You're welcome. You're welcome. So today we've learned internal and external hemorrhoids. We've learned thrombosed external hemorrhoids as well. We've learned pruritus any. We've learned perianal abscess. We've learned anal fissure. We've learned anal cancer, rectal prolapse, anal fistula, fecal incontinence, and pilonidal disease. One thing we did not touch base on will be inflammatory bowel disease, but that belongs to another objective altogether. And with these topics, we've literally covered that whole objective. And remember that you are expected to know how to make the diagnosis based on history and investigations. And we've learned that it is not every one of them that you quickly request an anoscopy right away. So I want to take you back to this, and then you ask yourself, have we fulfilled all that? Number one, this is how you're going to be examined. Assessment and diagnosis, acute and chronic. They carry the highest areas on the exam, and then management. So that's why you see that I've put in a message there. I want to give us an assignment, and I want us to discuss that assignment on the Facebook, on the Facebook group, the free Facebook group. How will you manage a patient with internal hemorrhoids? How will you manage a patient with external hemorrhoids? How will you manage a patient with thrombosed external hemorrhoid? How will you manage a patient with pruritus ani, perineal abscess, anal fissure, anal cancer, rectal prolapse, anal fistula, fecal incontinence, and pilonidal cysts? We've learned how to identify them. We've learned how to make the diagnosis. Now the final part is, how will you manage each of them? If you're able to go through this list, perianal abscess management. In fact, we learned the management for a lot of them, like the perianal abscess, the anal fissure, we've learned that. The rectal prolapse, we didn't do that. The anal fistula, we didn't do that. So it's left to just a few of them. If you're able to learn how you're going to make the money. So let's start. I want somebody to volunteer. How would you diagnose internal hemorrhoids? How will internal hemorrhoids present? Just a few words about internal hemorrhoids. Then we move on to the next one as we try to wrap things up.
Bleeding, paleness, and it will be above the dented line.
Mm-hmm.
Yeah.
And how would they manage it usually?
With the hemorrhoid deck.
Band ligation. Band ligation.
Most of the time they may do a band ligation, right? Band ligation.
Band ligation, yeah.
And that's what, okay. What about
thrombose?
Somebody can try thrombosed external hemorrhoid.
Incision and thrombectomy.
But how will the patient present?
But if the patient has if it has no non-viable skin, then we will refer the patient.
But how will the patient present?
Present with
painful,
mm-hmm.
And they will be bleeding. Yeah, it will be below the dented line. Yeah.
Will they bleed all the time? At times it will be.
No, not only when it will be thrombosed. It will not bleed all the time, but only when they will be thrombosed. Yeah.
Okay. Can I get another volunteer for pruritus any? How will pruritus any present?
The skin tone will be the color, the area of the skin will be looking normal.
Beautiful.
You get pleuritis,
Mm-hmm.
and you get itchiness
Mm-hmm.
and it would be painful.
Yes.
Because it's a
Attacks.
hypersensitivity. Yes,
Yeah.
it'd be painful.
Okay. Can I get another volunteer for perianal abscess?
The perianal abscess, the pain is worsening or straining, and equally could be worsening on the ambulation. Then also the cause should be fever, like from what you said. Then the treatment management plan is incision and drainage. Antibiotics is not indicated.
But
yes.
Temperature, don't forget.
And the temperature will be high.
Okay.
Who will do the incision and drainage? Who will do the incision and drainage?
The surgeon you refer to the
Beautiful. Okay, what about anal cancer? What are the things which will point you to anal cancer?
The presence of
Bleeding,
the mass,
pain,
bleeding,
and mass.
and pain or
Pain,
discomfort.
bleeding, and mass.
Bleeding, pain, mass, and usually what's the risk factor?
Gay HPV.
gay people.
Gay men.
What about rectal prolapse? How will it present?
You see a protruding mass.
Protruding mass, and then you see some rugi on it, right? And most of the time, the beautiful thing about it is that it's usually protrudes like during
Maybe they will say constipate, chronic constipation.
Yeah. What about anal fistula?
Drainage, pain, and in the exam you can see the like another hole.
You can see another hole. Okay, beautiful. What about fecal incontinence?
Then the fistula, we made the sphincter, the tone sphincter. Remember you said something about that.
No, that is no. The issue of please.
No, it does not diminish.
Beautiful. But then the fecal incontinence, the sphincter tone is decreased. Okay. What about pilonidal cysts?
Most of the time, pain.
Pain. And then that one, so you're going
Discharge.
to serious images.
Discharge.
Exactly. So doctors, look, if you're able to master these, topics, plus your inflammatory bowel disease, I think you're good for this particular objective. Was there anything?
And then fistula said during before defecation, no, not fistula, it's fissura, the defecation before and after, they will have the pain, I guess. That was the fissura. Nobody said that's what I'm saying.
The fissure? Yeah, they may have the pain, and when they poop, then the pain can get worse.
Yeah, that's it.
Okay. So I think, you know what, we've done justice to this particular objective. Somebody wanted to speak.
Yeah, absolutely, Dr. Bruni. I had the opportunity, as I mentioned before, I've been in this class for about maybe 3 weeks. And by having your approach to the questions and the topics are very good, because you break it down in concepts and you break it down towards the MCC objectives. And I find it very, very helpful. And even with your med bullets, it gives us objectives on how to learn, how to management, how to diagnose. It's fantastic. And I just, it's really, really, really good.
Yeah, sure.
Yeah,
So
and I think, okay.
I mean, even myself, if like I said, it's with your videos, if I don't understand something, I just go back and I watch the video again.
Yeah.
And personally, it's a lot better than trying to notes.
And you can also reach out to me anytime anyway. Yeah.
Like I did today. I told you I did my mock, and it was it was okay. It was good. So thank you, Dr. Bruni.